Hi, welcome to About Breast Cancer. Today I am going to talk about the imaging differences between two types of breast cancer, invasive ductal carcinoma and invasive lobular carcinoma. And I'd like to talk about invasive ductal cancer or invasive ductal carcinoma first. Invasive ductal carcinoma accounts for about 80% of breast cancer, so it is the majority player. Invasive ductal carcinoma, as the name might suggest, arises from the cells that line the ducts or tubes that connect the nipple to the part of breast tissue where milk is actually made, called lobules. These ducts are microscopic. You have millions of them. And these cells are utterly uniform, almost like cobblestones on a cobblestone street. But every now and then, malignancy occurs and cancer cells arise from these cells. Invasive ductal carcinomas grow in a particular way. They tend the cells to adhere to one another. And so invasive ductal carcinomas tend to form tumors, a lump, something you can sometimes feel if it's large enough or close enough to the skin. And this kind of growth pattern, this tumor-like growth pattern, creates discrete masses, almost like a piece of popcorn on a plate, something with irregular edges, but clearly distinct from what's around it. On mammogram, this can be seen as an irregular mass, just like the piece of popcorn on a plate, oftentimes involving tiny flecks of calcium called microcalcifications, although this is by no means universal. Most often, invasive ductal carcinomas occur on the upper outer portion of a breast, although they can occur anywhere. On ultrasound, invasive ductal carcinomas create an irregular mass there as well, which is referred to as hypoechoic, or generally darker than the surrounding tissue, and it can have jagged edges and appear taller than it is wide. Those are some of the characteristics of invasive ductal carcinomas on ultrasound. As with mammography, on breast MRI, invasive ductal carcinomas present as an irregular mass with abnormal spiculated edges. The way blood flows through a invasive ductal carcinoma is fairly rapid, and so the enhancement pattern reveals an early rise with an early washout of blood, and that's in contrast to the invasive lobular carcinoma. Now, what about invasive lobular carcinoma? Well, they account for 15% of breast cancer, so they are a minority player. And invasive lobular carcinomas arise from the part of the microscopic breast tissue where milk is created in tiny cul-de-sacs referred to as lobules. When invasive lobular carcinomas occur, the cells that comprise them do not stick to one another quite as readily as the cells from an invasive ductal carcinoma, and so invasive lobular carcinomas don't really produce tumors quite as often. They present in a very different way, almost like a drop of ink in a glass of water, irregular and diffuse within the tissue in which it occurs. This can be seen on mammogram as a diffuse thickening of tissue, easy to miss and not a discrete mass. The distribution of invasive lobular carcinomas can occur in the lower breast as well, not so much in the upper outer portion of the breast, although this is by no means an absolute. Invasive lobular carcinomas can be bilateral. That is to say, you can have tumors in both breasts. They can occur as several different tumors in the same breast. and we refer to that as multifocal if it occurs in generally the same area, or multicentric if it is occurring in really varied parts of the breast. On ultrasound, as on mammography, invasive lobular carcinomas are vague looking. They may have borders which are hard to distinguish from the tissue around them, and the echo pattern is variable, so they can be very difficult to see well. As with ultrasound and mammogram, they can be vague on MRI as well, showing a thickening of the tissue, and the way blood flows to a invasive lobular carcinoma can occur more slowly than it does in the more common invasive ductal carcinoma. So a good question is, why does this matter? And there's nothing like a story to bring home the message. So I will tell you about a woman I took care of within the last month who was looked at over the course of several years with mammograms and ultrasound following an area of peculiar tissue, quite vague on mammogram, quite vague on ultrasound. And a biopsy was not done. I'm not sure why, but she grew concerned when the skin of her lower breast began to pucker. It began to grow in so that the natural contour of her lower breast was not smooth and rounded, but it was somewhat wrinkled in a given area. And when I saw her, that was evident with her sitting up, that her skin was sort of puckering, and it manifested itself even more so when I asked her to raise her arm. You could see how the breast tissue was pulling the skin in. And as it turns out, she ultimately required a mastectomy because of the size of the cancer, and it had invaded both the pectoralis muscle deep to the breast and the skin overlying the cancer in the lower inner part of her breast. So recognizing invasive lobular carcinomas early is important. If you are someone who has been diagnosed with an invasive lobular carcinoma, it would be prudent of the doctors taking care of you to get an MRI scan in addition to mammograms and ultrasound, both to get the best possible image of the cancer you are known to have, and also to rule out the possibility of other cancers in that breast or in the breast on the other side. Furthermore, if you have an abnormality on mammogram or ultrasound that doesn't go away and is not explainable, biopsy is a really good thing to have done.